Cijfers, niet heel veel.
I've been told to stand behind the microphone, so we'll see whether I'll remember that. So welcome to this session about equitable and sustainable healthcare across the globe. My name is Bram Wouterse. I'm an assistant professor at ESHPM. And I think for today what we'll do is we're going to kind of show you different aspects of the research that we do on health equity and equitable healthcare within our school, but also even outside our school. So the program is that I will start with a short talk about inequality during COVID. Then we'll have Professor Hans van Kippersluis, actually from the School of Economics, talking about the interplay between, let's say, genetics and environment in shaping inequalities in health. And then we'll have Eline Linthorst and Igna Bonfrer, who will do a very much interactive session, so you don't only have to listen, we'll also actively engage you in this session. And they will talk more about the global aspect, and especially about the access to vaccines across the world, and the interplay also between, let's say, health economic arguments and legal or law arguments. And I think that is also very, let's say, indicative of the work we do at our school. So we have a really multidisciplinary approach here today. So again, let's start right away. And yeah, so if you're the chair, you can start yourself, it's always ideal. So I'll talk about inequalities in mortality before and after COVID-19. And with a small addition, so I'll only be talking about the Netherlands, so this is not so much across the globe yet. And when it comes to COVID, I will only talk about 2020. So you know that all the graphs I will show you, it's always the Netherlands, and when it's COVID, it's always 2020. So why talk about COVID in a session about equitable and sustainable healthcare? Well, I think that the COVID pandemic really has put a kind of magnifying glass on existing inequalities in health. So things that we're used to studying across several decades, we now have seen kind of developing in real time under our eyes. So that also, I think, makes it very relevant to study inequalities that, from COVID, because we can also learn something from that, I think, from tackling inequalities in normal times. And what I'll do today, I'll talk about a very specific aspect of how kind of pre-existing inequalities in health interact with inequalities due to COVID. And that particular aspect is the interaction between, let's say, prior health conditions and outcomes from COVID. So we know that people who are obese and people who, for example, already had chronic lung conditions, they were more susceptible, let's say, to severe outcomes from COVID. So more likely to die, for example, from COVID. And you can imagine that if also these kind of prior health conditions were more focused or were more prevalent among, let's say, lower socioeconomic groups, then that shapes kind of the outcomes that COVID has on the total inequality and mortality, but also in kind of the health burden in the sense of life years lost. So basically, and I will explain this later a little bit more, but basically you can think about the difference between did COVID add additional health burden to lower income groups, or did it kind of replace to some extent other health burdens? So instead of people dying, for example, from lung diseases, they would now die from COVID. And I'll come back to this a little bit more, how this works out. Yeah, I didn't realize that the screen would be so small, else I would have made a little bit different slides. But I'll talk about three things. So first of all, I want to kind of set the stage and talk a little bit about the trends in inequality and mortality in the Netherlands before COVID, to give you an idea of where we were heading before this pandemic hit. Then secondly, I want to talk about the effect of COVID on inequality and mortality in 2020. So to what extent did COVID increase the inequality in overall mortality in the Netherlands? And then lastly, I want to talk a little bit more about the health impact of COVID, so the life years lost. So how did COVID affect, so how many life years were lost due to COVID, and how does this differ across different socioeconomic groups? So let's start with the trends before COVID, and this is based on a project we did last year for the Institute of Fiscal Studies, and it was an international comparison where different teams compared the trends and inequalities in mortality across the world. And that was a very nice study, but one of the things that we had to do there is to make every country be able to do this. We had to rank people not based on their own income, which I will use later, but we had to rank them based on the poverty rate within the municipality that they live in. So what you see, I hope it's a little bit readable, but what you see here in this graph, so this is for 80 plus women. You see from the left, you have the 10% people living in the rich, let's say the municipalities with the least poverty, to on the right, the 10% of individuals living in the municipalities with the highest poverty rate. And what you then see in the different colors are the mortality rates across different points in time. So on top we have the blue dots represent mortality rates in 1996, then we have mortality rates in 2005, and then on the bottom in green we have mortality rates in 2016. And what you see here basically in this graph is two things. So first of all, old age mortality really has decreased quite substantially for all groups. So we see that the red lines are always below the blue lines, and the green dots are always below the red dots. So we see an increase or decrease in mortality rates at this high age, which is a good thing. But at the same time, you can see that this regression line that we plotted in there, the slope is actually increasing, which means that the inequality in mortality, at least in absolute sense, is increasing. So when you look in 1996, it didn't really matter whether you lived in the poorest municipalities or the richest, your mortality risk at 80 was the same. While now when you live, let's say 2016, when you were living in the poorest municipalities, your mortality rate was about 8.5 percentage points higher than when you were living in the richest municipalities. So quite a striking contrast. And of course I show this 80 plus women because that's the most spectacular, but we really see more or less the same patterns when we look at, let's say, a little bit younger group, so the 65 to 80 for women. And we also see, although again less spectacular, a little bit the same pattern when we look at men, both between 65 and 79 and 80 plus. So before COVID, we were actually seeing in the, let's say, the oldest groups where COVID would hit the most, we were actually already seeing a kind of stagnation or even an increase in the inequality in mortality. So then the question, of course, is what happened during COVID? So what we've done is we've plotted a new line in here, so the black line, and that is 2020, so the first year of COVID. And then again, when you look at these 80 plus women, you see two things. So first of all, COVID really put us back in terms of mortality levels to, let's say, the pre-2016 period. So mortality rates were actually higher than they were in the year 2016. At the same time, when you look at the slope of this black line, you see that at least for this group of older women, the inequality in mortality actually also increased due to COVID. So like I said before, there was an 8.5 percentage points difference between living in the richest versus living in the poorest municipalities. In the COVID year, this was 11 percentage points, so substantially more. And again, of course, I didn't choose this picture for nothing. It's because it's the most spectacular. When we look at a little bit less old women, we see actually that mortality increased, but the slope actually decreased a little bit, so we don't see this increase in inequality. And when we look at the men, we see the same patterns. We do see an increase in this slope, so the lines are a little bit more steep, but not as spectacular as you saw before. So this was about kind of to give you a first glance of, let's say, what happened before COVID and during COVID. And now I'll move into, let's say, more personal income measures, which give a little bit of a different picture. And also want to talk a little bit more about this substitution effect that I was talking about. So to what extent did COVID actually substitute other causes of mortality, and how does that affect inequality overall? And to explain that, before I go into differences across different income groups again, I just want to explain a little bit the different mortality concepts that we need to do that. So what you see here is a prediction of mortality in 2020. So what we basically did, we looked at the mortality trend before 2020, in the years before 2020, and then we just extrapolated that to make a prediction of what would have happened to mortality in 2020 if COVID would not have happened. So that's that orange dot you see there that's kind of extending at that line. Then we can compare that to actual mortality, so that's the blue dot for 2020 way there on the top. And so we can already again see that COVID increased mortality substantially above what we would have expected otherwise. But we can also compare it to this gray dot that's a little bit below there, and that is mortality from other causes. So we see two things. So COVID increased mortality in total, but at the same time, less people than expected died from other causes. Yeah, so what does this mean? If you think about the total people that died from COVID, that doesn't fully translate into what we call excess mortality above what we would have expected, but some of the people that died from COVID would otherwise have died from something else. So just like I tried to explain in the beginning. Now, what we wanted to find out is whether this, what we call substitute mortality, might be different across different socioeconomic groups. So is it, for example, the case that lower socioeconomic groups were more likely to suffer from this substitute mortality? And one way that you can see this, so this is now for men 80 plus, and I just realized that here the ordering is exactly the opposite. So the poorest are on the left, the richest are on the right, so this individual income. And what you see here is, in blue is COVID mortality, so all the people dying with cause of that COVID. And then in red you see the excess mortality. So we actually made predictions of what would have happened to these people if COVID would not have happened, and then looked at the difference with what actually happened. And what you can see is, of course, that blue, that the COVID mortality is always higher than excess. So you see for all these groups, you see the substitute mortality happening. But at the same time, you see that the regression line, so the red line for the excess mortality, is much less steep than it is for COVID mortality, indicating that indeed, among those lower socioeconomic groups, of these poorer groups, indeed substitute mortality, at least in absolute terms, played a more important role. And that kind of dampens the effect of COVID on the inequality in total mortality. Now, instead of showing you a million graphs for all different groups, what we did here, we kind of translated this into, I see that the title is gone for some reason, but we translated this into what we call, let's say, a measure of relative inequality. So what you see here are values of what we call the concentration index. I won't explain exactly what that is, but you have to remember that -1 means that all the deaths are concentrated among the poor, +1 means that all the deaths are concentrated among the rich. So that means the more negative these values are, the more unequal, let's say, the more concentrated are the burden of COVID among the lower income groups. And one thing that you can see, probably you cannot see, but when you would compare the inequality, for example, for the females between 65 and 79, we see that without COVID, we would predict that this inequality index would be something like -0.19, which is kind of, that's kind of in line with what we normally would expect. And now what we see that actually happened, so in the bottom, what happened to actual mortality due to COVID, we see that this is a little bit higher, but it's really kind of in the third decimals. Yeah? So COVID did indeed increase relative inequality, but only to a very small, that's to say very, but a small extent. Now, why is this the case? Two things. So if we look at COVID mortality, again, probably you cannot read this, but then you see that if you just look at COVID deaths, they are much more unequally distributed. So for example, for the same group of females between 65 and 79, we get values like -0.3. So if you compare that to the -0.19 that I was just talking about, the inequality is way larger. At the same time, if you would look at the share of total deaths, then COVID is it's about 10% of total deaths. So the impact of COVID on total mortality is not negligible, but it's also not that large. And at the same time, we have this substitution effect. And we see that also the substitute mortality is generally, except for males between 65 and 79, is generally more concentrated among these poorer groups. And this means that although COVID was very unequally distributed, because a relatively large part of these COVID deaths among the poor were substitute mortality, that actually means that the impact on total mortality, so let's say the net effect of predicted mortality plus COVID mortality minus that substitute mortality, is actually quite limited. All right. Now we'll come to the last part, and that is translating this a little bit further. So you can imagine, of course, this substitute effect can happen within 1 year. So now we just looked at 2020. But you can also expect that people that died from COVID might also be more likely not to die within 2020, but maybe 2021 or later. So what we want to do here is look at the effect of what we call life years lost. So how many years would these people that died from COVID would have lived if they wouldn't have died from COVID? And the way I'll do that is to again make a comparison between rich and poor. And in this case, what we've done, we just divided people in each age group in two groups. So 50% of the people in each age group we define as poor, being under the median income, and the other 50% as rich, being above the median income. And that means that we can directly compare total numbers because these underlying groups are the same size. And what you see here for men and women, you can see the total number, just a death count, so how many people died of COVID by age who were in high income versus low income. And then, of course, you can see that, I even have the numbers here, that for example, for the males, about 6,700 individuals died from COVID in 2020 who were poor, while for the rich it was only 4,000. So it's like a 50% increase in the total number of deaths among these low-income groups. And we see the same for women. Now the question is, what was the underlying health of these people? So what kind of prior health conditions did they have? And what we did here is we divided these total number of deaths into three groups. So we have people that we call healthy, then we have people who have comorbidities, which means that they used medication related to diseases that make you more susceptible to a COVID infection. And then we have people here in black. These are people living in nursing homes. And I think what's very interesting to see here is so this is only the men, but when you compare the low incomes to the high income groups, you actually see that the number of healthy people that were either rich or poor and died from COVID is more or less the same. But where you see the large difference is in this red line and a little bit in this black line. So indeed, among the poor, it are mostly the additional mortality among the poor compared to the rich mostly comes from more people with lower incomes in poor health dying from COVID. And this kind of relates back to what I showed you earlier, to the substitution story. So apparently, a much larger share of COVID deaths among the poor already had prior underlying health conditions. And why does this matter? If you think about how many life years would these people have lived, you want to take into account that if you have comorbidities, probably your life expectancy is already a little bit lower than that of the average population. So we want to take that into account. And that's what you see here. So this is kind of the 2019 or pre-COVID life expectancy, which we'll use to calculate kind of the counterfactual scenario of how long these people would have lived otherwise. And probably, again, it's not super clear to read, but what you can expect is that, of course, healthy people at each age have a much higher remaining life expectancy than people with comorbidities, and especially at higher ages than people who are living in a nursing home. So, for example, if you're a man you're 80 and you go into a nursing home, your life expectancy is something like 5 years, while when you're still healthy, it's more than 12 years. Okay, so how does this translate into life years lost? So we just multiply these two pictures that I saw before. So the number of deaths by cause times the number of remaining life years. And then we get this picture, and I think this one is even more clear, where we add everything up. And then I think you see something quite striking. So again, the straight line are the low-income groups, the dotted lines are the high-income groups. And what we see is that even on an individual level, let's say poorer incomes had less to lose, so they had a lower life expectancy than people with a high income dying from COVID. Still, the overall burden is much higher for the poor income groups, and actually showing that indeed poor income groups were exposed to such extent to, let's say, the negative health consequences of COVID, that let's say the sheer number of people dying from COVID within this group kind of overrides the fact that they had a shorter life expectancy. And that's also to get to the conclusion. So inequality in COVID-19 mortality partly reflects this higher susceptibility to severe health outcomes due to worse prior health among the poor. So that's what we saw. And this relatively large share of COVID-19 death among the poor with already prior health conditions that kind of dampens the inequality in total mortality. So we see that that's a little bit lower than you would have expected if all these deaths would be in excess of normal deaths. And we also see that it dampens the burden of disease. So the life years lost are lower because a lot of people, especially in these low-income groups, already had prior health conditions. Still, and I think that's the main message here, still COVID-19 increased the inequality in total mortality, And the burden of disease was still, for the group as a whole, still higher among the poor than among the rich. And then I have 2 points to think about for discussion. I think the first one is, so kind of the number of life years that we saved, or the number of qualities that we saved through, let's say, the measures we took against the COVID virus, has been in the policy debate an important parameter. So there have been a lot of discussions about, yeah, but now we're taking all these measures, but how many life years are we actually saving because these people are already in poor health? And I think we can kind of see the same kind of discussions where we think about, the cost effectiveness analysis, where we look at the number of qualities that we gain from doing a certain intervention. But how do we deal in those cases with equity concerns? And especially if we know that this poor health is already, let's say, concentrated more among the poor. So if we do an intervention and we really look at the life years that we can save, then we will always favor interventions targeted at the rich and not at the poor. And that is just one thing I think we can, for a broader discussion. And the last thing is, I think what we need to understand better is actually how this kind of differences in what you have to lose from the virus interact with, let's say, behavior both at the policy level, so to what extent did policymakers take these equity concerns into account, but also at the individual level. Did people actually behave differently if they knew that they were already in poor health, so they, in that sense, had less to lose? And I think that's a very interesting question also to think more about cost and benefits of policy. And that's it. I have no idea how we're doing on time, whether we can still take 1 or 2 questions, but... Oh, one, okay, yeah. Yeah.
I was wondering, do you know what drives this difference? So is it that those who are worse off when they get COVID, they don't necessarily get the treatment that helps to save them? Or are there other reasons? Is it mostly this susceptibility making them less likely to survive?
Yeah, so when we look at the underlying causes that were actually substituted, then you see kind of the things that you would expect, like lung failure, but also, for example, dementia. So there are a lot of people already living in a nursing home, and they were kind of more exposed to the virus. So I don't think it's mostly treatment, but it's this combination of the higher prevalence of these diseases that make you more susceptible to worse outcomes from COVID among the poor. And the other one is the extent to which people in these poor health conditions were able to protect or self-protect against the virus. So you can imagine, even if you have lung conditions, but you are rich, you might still be able to better protect yourself from the consequences than someone with the same conditions who is poor. And that's also something that we want to look further into and actually look at, okay, but how many of these people still had to go to work, for example? How many of them wore face masks, stuff like that, yeah. Yes? Yeah, that is basically the dying of COVID or dying with COVID discussion that we've seen a little bit in the Netherlands. Yeah, that is a good question. So I think, the cause of death registration in the Netherlands is quite good. So, and they look at let's say the underlying cause. So for example, in normal times, if you fall from the stairs, but you fall from the stairs because you have dementia, you don't die from falling from the stairs, but you die from dementia. And I think they do the same kind of philosophy here. But of course that is true. So when you think about, for example, people with dementia in a nursing home in a very severe stage getting COVID, maybe you can say they died from COVID, but indeed, else they would certainly die from the dementia as well. And it can be difficult to distinguish that. I agree with that, yeah.
Did you look at specific causes? Because I would expect that things like pneumonia are maybe reported less often, while things like COVID get difficult to sort of disentangle.
Yeah, so you see it, so like I said, so you see it both in kind of the lung and related conditions. And you also see it among people with dementia. Those are the two. So you can imagine that if you go deeper into these causes of death, you get trends that become a little bit less interpretable. But I think the usual suspects for getting worse outcomes for COVID are in there, and then dementia, which are probably people living in a nursing home that was infected by COVID, and who would otherwise also have a very low life expectancy and now dying from COVID because they had entered their nursing home. Yes.
I was wondering, is the care different in nursing homes between the rich and the poor in the Netherlands?
No, so I think there's actually a good study from Belgium that looks at kind of mortality also within the nursing home, and you see once you are in the nursing home, it doesn't really matter whether you're poor or rich, which also makes kind of sense. Well, it's getting a little bit different, but nursing homes are kind of equalizers. So whether you're poor or rich, you go to the same kind of facility. So it makes sense that once you're in the nursing home, it doesn't make a difference. But we do see a large difference in the use of nursing home care between the poor and the rich. So the rich are more likely to to stay at home and receive care there. So in that sense, they were less exposed to kind of the COVID death hitting the nursing homes. And I see Igna pointing towards the watch, which I think is a good thing. So I'll now give the floor quickly to Hans.
All right, thanks, Bram. And thanks also for the, thank you, Bram. So my name is Hans Kippersluis. I'm a professor of health economics at the Erasmus School of Economics. And let me first say thank you for having me. Thank you for inviting me to join this session. And to celebrate the 40 years of ESHPM with you. I mean, apart from the quality of research and the impact that has already been mentioned in the keynotes, I think it's also good to say that I always enjoy the open-minded and constructive atmosphere if I enter the building of ESHPM, but also when I interact with colleagues. So I'm very glad to be here and enjoy this celebration with you. So today I'm going to talk about also health inequalities, and I'm going to extend the discussion on equity and inequality, but in a very different direction. So I'm not going to talk about COVID at all. I'm going to talk about more sort of the interaction, the interplay between genes and the environment into inequalities. And because I think what is interesting is that if you sort of consider studies in health inequalities, then traditionally we always talk about nurture. We talk about parental income. We talk about parental education, your own education. And there are striking inequalities in health and life expectancy across socioeconomic indicators. And so I think it's completely justified that there's a lot of attention for this. But what I think is interesting, and that's the conversation I would like to have today, is that there's also an interesting conversation to talk about genetics. There's many advances in genetics, in the nature of things in recent years. And there's many availability, new opportunities rising up. And I think the most prominent ones are perhaps in personalized medicine, but also in testing theories. But today I want to talk about two different things, two sort of applications, if you like. The first one is, what is the interplay between nature and nurture, genes and environments, into health inequalities? And secondly, I want to sort of start a discussion basically on what is inequality of opportunity. There's also a lot of discussion about inequality of opportunity, and I think that genetic data can also enrich the discussion of inequality of opportunity. So these are the two things I'll talk about today. So first, gene-environment interplay. And let me first sort of start by saying that, we all know that both nature and nurture matter. It's not a discussion of nature versus nurture, both matter. And especially in the fields of health, I will talk about cardiovascular disease. It's been very well established that both your genetic makeup, your genetic risk for cardiovascular disease, but also your socioeconomic environment and other choices that you make are influencing your cardiovascular disease risk. But what is interesting is that these two fields of study have developed rather independently. Geneticists and biologists have studied nature, have studied genetics, and social scientists, like most of us, and including myself, have studied nurture, have studied socioeconomic determinants of health, socioeconomic inequalities in health. But now recently, it has become possible to study the interplay between the two, because genetic data has been increasingly added to social science surveys, and now this is the first time that we can actually study interactions between the two. So that's what we have been doing over the past years, and I will give you one example here from a paper joined with colleagues from Bristol and Bologna. And again, I will talk about heart disease. And heart disease is interesting because heart disease is famously known for the Barker hypothesis that most of you will be familiar with. So this is the hypothesis from an English physician who talked about the relationship between the infant mortality rate in the area where you were born and your later life heart disease risk. And what he's been showing, and this is a picture actually from our paper, but it basically replicates the initial results from Barker, is that there is a pretty strong association between the infant, the infant mortality rate in the place where you were born and your later life risk for ischemic heart disease. And the idea from Barker is that this has to do with the nutritional environment when you were born, or even in the womb of your mother. So the idea is that the conditions early in life, and in particular also during the pregnancy even of the mother, are influencing your later life disease risk. And what you can see over here is that people who were born in an area where there was a very low infant mortality rate, they also tend to have a lower risk on cardiovascular disease later in life. Whereas if you are born in an area that had a very high infant mortality rate, your own risk of developing cardiovascular disease later in life is much higher. So this is sort of the standard Barker hypothesis, if you like. Now what we also know is that heart disease is partly influenced by your genes. Biologists, geneticists have studied this, and what we do over here is developing an index, a score, a polygenic risk score, if you like, of your genetic risk for developing heart disease. And what you can see is a pretty similar picture. For people with low genetic risk, the odds that you actually develop cardiovascular disease are pretty low, whereas if you have a higher polygenic risk score, then your own chances of developing cardiovascular disease are higher. So both of these lines go up. And we were the first, I think, to sort of look at the interaction between the two. So we know that nature matters, we know that nurture matters, but is there any interaction between the two? And this is what we found. This is sort of a simplified graph on basis of the model estimates. But what you can see is pretty interesting. So again, on the x-axis it says the infant mortality rate, and -2 means areas with the lowest infant mortality rate, and +2 means the areas with the highest infant mortality rate. And the 5 different lines are for individuals or groups of individuals with higher or lower genetic risk. And what you can see in this picture is that when the infant mortality rate is very low, -2, so 2 standard deviations below the mean of the infant mortality rate, what you see is that genetic risk hardly matters. If you grow up in advantageous environments, in good nutritionist environments, higher socioeconomic environments perhaps, then your genetic risk hardly matters. But if you move to the other side of the spectrum and you look at areas in which there was a lot of infant mortality, so probably bad nutrition, a lot of deprivation in your area, then what you can see is that genetic risk matters a great deal. And what we find is that even if you look at the mean effect, so basically here, somewhere over here, then the average effect is even not statistically significant. It is only among, another way of looking at this, I should say, is that only among the ones who have higher genetic risk, this infant mortality rate even plays a role. So I think this is telling us 2 things. One, it's telling us that looking at the average effect of the infant mortality rate or nutritional conditions when you were born is sort of masking or hiding a lot of heterogeneity by genetic risk. So genetic risk is sort of an important source of heterogeneity in the effect of the infant mortality rate. But what I think it also shows is that if the environment is good, then you can basically decrease genetic risk for heart disease. And I think that's a very interesting also policy conclusion, is that if you're worried about genetic risk, and we will talk about that later in the second part of the presentation, if we should be worried about genetic risk, then sort of improving the environment is also a way of trying to reduce genetic risk and inequalities in heart disease with respect to genetic indicators. So I think this is quite an interesting setup also for the second part of this presentation, which is talking about inequality of opportunity. And there's recently been, especially in the Netherlands, but maybe also elsewhere, there's quite a bit of attention for equality of opportunity. There's 2 documentaries, Sander and de Kloof and Klassen. Maybe some of you have seen it or heard about this. And this is all about sort of the concept of equality of opportunity. And I consulted Wikipedia a few weeks ago, and the definition that is given there is that individuals should succeed or fail based on their own efforts and not extraneous circumstances such as having well-connected parents. And if you read that sentence, it's hard to be against it, right? I mean, I don't think anyone would object to the concept, to the ideal of equality of opportunity. And in fact, it's also been embraced by political parties across the entire spectrum. Everybody seems to be in favor of equality of opportunity. So let me give you first a thought experiment in order to sort of tease you a little. And I was thinking of doing this through Mentimeter, but given the size of the room, let's just do it by some hand, holding up your hand. So let's sort of do a thought experiment in which there are 3 possible societies. Society 1 is where your level of education depends only on the income of your parents, so an aristocracy, let's say. Society 2 is where your level of education only depends on hard work. And society 3 is a society where your level of education depends on talent and hard work. And let's make it simple, let me assume that society 1 is not the one you are willing to live in. So let's sort of focus on society 2 and 3. Who would be in favor of living in society 2? 1. 2. Talent is sort of your inborn skills and sort of talents to sort of make you flourish in education. Who would like to live in society 3? Most of you.
Sorry, why wasn't society 2 available? Because everyone would prefer that one?
No. So I asked about society 2, sorry. I didn't ask about society 1 because I thought that society 1 would be the one that is least preferable here. Okay, well, so yeah, there's a few of you who would like to live in society 2, and most of you favor society 3. Now let me give you another thought experiment, and let's move the discussion from education to life expectancy, to health. Society 1 is where life expectancy, again, then depends only on the income of your parents. Society 2 is where your life expectancy depends only on a healthy lifestyle. And society 3 is a society where your life expectancy depends on your genetic risk, for heart disease, for cancer, whatever, and also a healthy lifestyle. Now let me ask you the same question. And again, let's avoid society 1. Who would like to live in society 2? Who would like to live in society 3? Okay, so now it's more or less 50-50. What is interesting is that I sort of changed the framing. I changed the outcome from education, I should say, to health, to life expectancy. And also some of your opinions changed. Not all, but some of your opinions changed. And I think this is sort of the first reason to be talking, we need to have a discussion about this. We need to have a discussion about genes. Because apparently it matters, and I think that's somehow strange, that some of you think that, when it comes to education, then, it's your own talent that should determine whether you should be rising into education, maybe earn a higher income. So their talent is seen as something like advantageous and sort of your own merit. Whereas if you move the discussion to health, then we suddenly think, at least some of you think, maybe we should try to live in a society where genetic risk, where the other side, genetic disadvantages, do not play a role. Yes? I see. Okay, fair enough. Thanks for your... I agree. So basically I'm not changing one thing here. I'm not changing just the outcome. I'm also changing the framing of healthy lifestyle and hard work, which could be perceived differently. I agree with that, yeah. But let me say that the first thing I would like to say is that apparently, at least for some of you, the discussion changes when it comes to, genetic advantages and genetic disadvantages. And that's, I think, a fact now. Let me say another thing. And I think what is interesting is to sort of think about the distinction between nature and nurture here. And whether there is actually an actual distinction or whether this is somehow fuzzy. And honestly, I think it's fuzzy. Because if you think about, the child's outcome, let's take again health, then of course, by definition, you have genes and the environment, so both of them matter, right? So your child's genes and your child's environment matters. But if you think about how they come about, then of course the child's environment is shaped in part by the parental background, by parental education, parental health, and so on. And if you think about these two things, so the child's genes and the parental background, then at least to some extent, they are both shaped by the parental genes. And I think that is somehow funny then to sort of distinguish between parental background and saying that, your parental background is sort of an unjustified source of advantage in life. Education shouldn't depend on your parental background. health shouldn't depend on your parental background, but that we say that your genes, well, your own doing, your merit, and perhaps to a larger extent in education than in health. But I think that's funny, because basically it is completely random which genes you inherited from your parents. And it's the same genes from your parents that partly shape the environment in which you are born. So why make a distinction between these two? And in fact, as we have just seen in the previous paper, there is actually an interaction between the two. Child's genes and the parental background are not completely independent from each other. So that's a discussion I would like to start, and that's also why I think genetic data can be really an enrichment to the discussion of equality of opportunity. Most people have focused on this part, inequalities with respect to parental background. And the claim I would like to make here, and the discussion I would like to start here, is whether we can see this independent from your genes, and whether genetic data shouldn't be like also on the table here, and an enrichment of this discussion. So what will I do? And this is just a peek preview into my own research agenda. I would like to study more about how these nature and nurture sort of shape inequalities. How do they interact? What is the interplay between the two? And more generally, and this is sort of one example for years of education that we recently worked on, in which sort of the inequality in education with respect to, for example, maternal years of education is already large. But if you sort of bring genetic data into the picture and make this sort of a three-dimensional plane, then what you see is that the total inequality of opportunity, if you accept that genetic risk or genetic advantages are also just some random component, let's say, of your advantages, is actually much larger than what we previously thought. So I would like to sort of create at least more awareness of this social and genetic lottery. And hopefully I would also like to contribute to sort of a quote by one of the Nobel laureates in economics, finding some effective method of offsetting the unmerited favors that some of us receive from our genes and family advantages. So let me leave it here. Thank you. Other comments, questions? Yes?
How do you think about epigenetics playing a role in this discussion?
Yeah, epigenetics is interesting. I mean, so the way I think about epigenetics is that it's, let me start differently. The nice thing about genes is that they are fixed at conception. There's really literally nothing you could have done to change your genes. Epigenetics is a bit different because epigenetics can be influenced by smoking decisions or by your own behavior. And that's why I think epigenetics is sort of a slightly different and more difficult concept because it can change over the life cycle. It can even change in this part of your body from this part of your body. So genes sort of keep it simple because it's the same in every single aspect of your body and it's fixed at conception. So I think epigenetics clearly plays a role, especially in the interactions between genes and the environment. But I cannot really wrap my head around how I should think about epigenetics in the context of equality of opportunity, because it's partly shaped by your genetics, but it's also partly shaped by your own choices. So that's what makes it a bit more difficult to think about.
I think what I find interesting is it's your own choices as well, right?
Yes.
So thereby you're shaping your genes.
Definitely.
And thereby changing.
Well, not your genes, but your genetic expression. Yes. Yes. I agree. Yes.
So with regards to the scenario you just gave, Mr. Trish, would you say that having talent is a form of inequality?
It's hard. I mean, I'm not a politician. I'm a scientist. I'm just trying to raise questions here. So I don't think, I mean, I have my own opinion, clearly. I don't think it is a scientific question. I do think that, you know, part of your talent is determined by your genes, and it's a fact of life that this is fixed at conception and you didn't have to do anything for it. So I guess from an efficiency perspective, you could still say, well, it's a good thing that the most brightest kids go to school and you know, help build a society. But I think it's another question whether that sort of justifies large inequalities in income, for example, according to education. And so that's sort of the difficult part here. So I'm perfectly fine with talent playing a role in education. I have a bit, if you ask my personal opinion, I have a bit more trouble with this leading to sort of huge inequalities in income and wealth. First Peter and Bram. Yeah, mainly because I think the answers probably for income and health are more similar than for education and health. So I wanted to sort of raise this contrast.
Yes, but that also raises the question, so
Yes.
Health is an outcome, income is an outcome, and education is more instrumental. So is that a fair argument probably indeed what you have mentioned, income or health more simplified. And you have all kinds of policies, both in health
Hmm.
and income, to sort of, well, to take into account this sort of general preference that we want to have some equalization policy.
Yes. No, I agree actually with you, and I was doubting, but because of the time constraints, I didn't do it. Is to have 3 thought experiments, one also including income, and I would be very interested in seeing whether, I mean, this education life expectancy thing creates a large contrast, and that's exactly what I wanted to achieve here. Income, I would be surprised. I would actually be interested in hearing what people's views are on income, because I definitely agree that that's more of a fair comparison than this one. Yes. Bram?
Yeah, my remark is actually the extension to this. I found it interesting that you quoted Merlis at the end, because that's about taxation. And maybe that's, I think maybe this kind of genetic environment interaction, but also the differences how we think about these two things. Is actually, I'm a bit of an old socialist, but it's also a good argument also for doing some ex-post redistribution. So I think it makes sense that the most talented people get the highest education. Probably makes sense that they are the most productive, they earn the most, but we can redistribute part of that also. And I think maybe now the debate focuses very much on this equality of opportunity, but this might also be, but maybe it's just my opportunistic own political views, but also actually a good reason to think about that still we also need kind of ex-post old-fashioned income redistribution.
Yeah, I very much agree. I think you could take this both as an argument for ex-post redistribution, but I don't think there's further questions so to leave you with a very provocative idea. Maybe we should tax genes.
Yeah, so that's kind of Tinbergian idea, that you tax talent.
Yeah. I'll leave it there. Thank you.
Thank you very much, Hans. Very exciting presentation.
Ja, hier heb jij een.
Welcome to the last part of this parallel session, in which Eline Linthorst and I will talk you through some of the challenges that persist when you are looking at inequities worldwide from sort of a health economist perspective and more from a legal perspective. So what we're doing is we are taking the discussion a bit further, so we're moving away from sort of the Netherlands or high-income settings, and we're interested in more of a worldwide perspective. Specifically, we're interested in inequities in access to COVID vaccines around the world and how that relates to our existing right to health. We will talk you through this and we'll ask for your input. Hopefully you'll be able to use Mentimeter. We'll get from some technical support for that. And first we'll look at the Sustainable Development Goals and this idea of ensuring that everyone has access to, for example, vaccines. What is this right to health? And what are the tensions between the right to health and existing international arrangements? And we will end with this idea of maybe some kind of global health law or the ideas that are currently in place for a pandemic treaty and who should be taking the lead in such an initiative. Good. Let me start from the Sustainable Development Goals. Now, in the area of global health economics, so often focusing specifically on low and middle income countries, there is a lot of attention for the goals that have been set by the United Nations in 2015 to be reached by 2030, where one of the important goals is to reach good health for all and well-being for all. Now here in this image we suggest that this third goal is actually central to the whole agenda, but obviously others who might be working in the field of clean water would argue that that is central to the SDG agenda. But if we focus on this third goal, an important target is to reach universal health coverage. Universal health coverage consists of 3 elements, and we're always interested in progress that countries or areas or continents are making towards this goal. So there's 3 elements, and they're often represented using a cube. So the first axis relates to the population. Which share of the population has access to healthcare services? We're interested in the type of services that people have access to. So that could be, do people have access to the COVID-19 vaccines, but also they have access to antenatal care, to a wide range of healthcare services that are essential. And thirdly, what share of the costs are actually placed on the user? So how much do they pay out of pocket? And which share is actually covered through pre-financing schemes like a health insurance or a tax-based system. Now, no country in the world has reached universal health coverage. Even when you can think of like very advanced healthcare systems, maybe Scandinavian countries, Netherlands, some people would argue the US, then it's for still, an important challenge remains with the population. So often, services are not equally accessible to everyone. In the Netherlands, a study a few years ago by our colleague Karin Uil showed that women with breast cancer, the same type of breast cancer, receive different drugs depending on where they live. More innovative versus more traditional drugs. So here we're really interested in sort of who has access around the world to COVID-19 vaccines. And this map shows quite clearly how inequities in vaccines are distributed around the world. Now, countries which are dark green have reached what it says 350% coverage. So that means on average 3.5 vaccines or vaccination doses per person. And the contrast with especially sub-Saharan Africa is quite large, as you can see here, where large shares of the population have not received any vaccination so far. So there I would like to take this one step further and show you that if we look at COVID deaths, we more or less see the opposite image. So what we see here is distributed by high income, middle income, and low income countries, deaths due to COVID. Now, obviously, these are reported deaths to COVID, so it's likely that in certain settings there's underreporting. But even studies trying to account for this underreporting still suggest that COVID deaths tend to be higher in high-income countries. So now my question to you, for which I'd like to move to Mentimeter, and as you all know, you just have to put in the code that will be shown in a little bit. And I can already tell you what the question is going to be, so I'd like to know if indeed deaths in low-income settings are considerably lower, should we then maybe focus our vaccine efforts on middle and high-income countries? Yeah, so here you can see the code. So it's 10980435. And if we move to the next slide in the Mentimeter, then we will get the first question. Perfect. So let me repeat the code one more time. It's 10980435. So the question is, given relatively low reported mortality in low-income countries, should we consider focusing our vaccination efforts only on middle and high-income countries? Yes, no, or hard to say. I will wait one more moment. Okay, so it seems overall that a few people would argue, indeed, we should focus our efforts only on middle and high-income countries. The majority says no. I interpret this as we should also focus our vaccination efforts on low-income countries. And there are also quite a few people who are saying, well, that is hard to say. Now, obviously, it is quite hard to say. And if we can move back to the PowerPoint presentation, then I will explain to you a little bit about what earlier work found when it comes to asking those in low-income countries who have not yet had access to vaccinations. So there we find it was our colleagues Kanyada et al. They found that 4 in 5 people across most sub-Saharan African countries indicate that they would like to receive a COVID-19 vaccination. So, of course, there is like this whole debate around should people have access to vaccines? Should it be mandatory to take a vaccine? But I would like to sort of leave that discussion aside. But I want to focus here on the fact that if you ask those across a range of sub-Saharan African countries, that more than 80% says we would very much like to receive those COVID vaccines. Now, quite some progress has been made. So across sub-Saharan Africa, more than 580 million vaccine doses have been basically flown in. So here we're talking about the vaccines that have entered the country. The majority have been provided through this COVAX initiative that I think most of you heard of. And some of the vaccines came in through bilateral deals and specific actions from the African Union. Now, the challenge, however, is to ensure that those vaccines become actual vaccinations, so that they actually reach those who are in need of the vaccines, because a large share of vaccines have remained in storage so far. Now, having sort of shown you this picture of inequalities in access to COVID-19 vaccines with a focus on sub-Saharan Africa, I'm sharing with you this quote from the executive director, Michael Ryan of the WHO, and he basically says there is still a deeply unfair, inequitable world in which the basic human right of health is something that's given by privilege and by those who have money. So this is this sort of bridge to the concept of human right, for which I'd like to hand over to Eline.
Thank you. Yeah, I'm not sure. Yeah, is it working? I'm not, yeah. Thank you, Igna. Thank you for this beautiful pictures, and I think it's very visual to see that we can speak of inequalities in the access to the vaccines. And well, I am quite aware that amidst this group, I might be a little bit of an outsider as a lawyer. So yeah, it reminds me on a little joke. So what's the difference between a lawyer and an accountant is that the accountant knows that he's boring. So I hope I will not bore you too much with too many legal texts, but yeah, I'm afraid that it's going to be a little bit necessary to have slides with a lot of legal text, but I'll work you through it. So we saw on the previous slide the quote of Michael Ryan stating something about the basic human right to health. Well, what is it exactly? I'm going to try to explain a little bit more, and also where do we find it, the right to health? And why does it relate actually also to the topic of our presentation, the unequal access to the vaccines? Well, we see in one of the oldest declarations on the right to health in an international law context, we see that the right to the enjoyment is the highest attainable standard of health of every human being. So why not just the highest standard? Well, that is a common misconception that the right to health is equal to the right to be healthy. So that is not the case, because there are, of course, some important factors that are outside the control of the member states, such as the biological makeup of a person or socioeconomic position. So yeah, it's not the right to be healthy, so there's not some unconditional right to be healthy. What is it then? It's we could say that the underlying determinants of health should be realized by the state. So we're talking about safe water, not only the building of hospitals, but also other conditions to be healthy. Well, not to be healthy, but to realize the right to health. And an important principle in this obligation is the principle of non-discrimination and equality. So the state should prohibit and eliminate all discrimination on all grounds, and should make sure that's an equal access to health care. So it's an important principle. Where do we find this right to health? Well, as you can probably imagine, it's not at one place. So we see at multiple legal instruments, both at the national, regional, and international level. So national level, I think there's almost 120 countries having the right to health in their constitutions. We have at the regional level, we have the European Social Charter, for example, and at the international level there are multiple treaties, and we can say that almost every country is at least a member of a treaty that also contains the right to health. But the most referred to, and also in our case the most relevant for us today, is the International Covenant on Economic, Social and Cultural Rights. And if we zoom in to Article 12 there, and even more up close, Article 12 under C, we see that the state should take all the measures necessary to achieve the full realization for the prevention, treatment and control of epidemic diseases. So, let's go back. So then the question would be, if we have such a beautiful legal framework with all these, I could say that 171 countries had ratified the earlier mentioned convention. So given the low vaccination rates and the difficulties in the access to the vaccines, could we state that those countries that have low vaccination rates, do they actually violate the right to health of their citizens, giving these low vaccination rates? So what would you think? Hard to say. Maybe that's because of we of course need some more details on this, I can imagine, but maybe something that you just feel. Okay, so most of you, hard to say. Somebody wants to say a little bit on his answer to that says no, it does not violate the right to health. Yes? Aha, okay, yes, yeah. But the right to health is not only the unequal distribution of healthcare, but also having the right access to the medicines and the vaccines. And does that make a difference, maybe? Some. Yeah. 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 Okay. Yeah. You can word it, Lisa. Beautiful. Yeah. Yes. I can understand what you're saying, and I think. Well, maybe someone wants to say yes. Explain his answer. That is yes. Maybe it's nice. Yeah.
Yeah, sure. I have a friend who lives in Congo, and during the whole pandemic, we were discussing how the government was handling things, and yeah, she was talking to me about how, for example, they would increase the number of deaths from COVID just to get more money from WHO, for example, or yeah, things like they would have vaccines and stuff, but she got a fake vaccine passport.
Oh wow.
And she's very well off over there, like very, very well off. So she doesn't, yeah, she has education, she has income. She just felt like she was not needing the vaccine, but she still went and got the fake, the passport to travel
Yeah.
and just
Yeah.
whatever around
Yeah.
the country. So I just think that there is a lot of corruption through the whole process. I think the vaccines are available, but yeah, I'm not sure how much people want to actually take them. But yes, probably it depends where you look or who you ask. But a lot of people also are just, yeah, hush hush money and just trying to get the passport. And I just think the government knows all this already. They know what, yeah, their people are like, or
Yeah.
they should try to tailor policy a little bit better so that people can actually know what is the vaccine, why should they take it, you know, like have it clear and have, yeah, I don't know. I think they receive also a lot of vaccines for free, no? Or anyway, that's what
Well,
I saw.
I think so. Yeah. Yeah, well, I think this is exactly also a problem. I'm not sure if that is a violation of the right to health, but the corruption and the, I think in the way it's distributed, the vaccine is also a problem. But I think I can also relate to the answer no. If we go to the slides again. Since it's exactly what Peter also was stating, that well, do we actually recognize certain the economic realities in a country in our international law regime? And I think yes, we do. If we look at the Article 2 of the Covenant, we see that there's an implicit recognition that states have resource constraints, and it takes time to implement the treaty provisions and the obligations. So, yeah, it's quite, when assessing whether a country is actually in breach of the right to health, I think it's, we could still recognize the economic reality, and especially in the distribution of scarce goods, which are the vaccines. And that's why this concept of the progressive realization is made up in the legal framework. So, and the other difficulty is, of course, that we make the distinction between negative obligations and positive obligations when regarding the human rights framework. Maybe you know the distinction between those two, that like the negative obligations are more related to the more classical and first generation human rights, like the privacy rights, or where you actually want the state to not interfere too much with a person's lives. And then the second generation human rights, which are the social and economic rights, which asks for positive actions from governments. And those are not so precise, and there is a lot of margin appreciation, we would call, to what measures actually should be taken by a country. And there is also that recognition of the resource constraints. There are exceptions, though, in which a domestic court, actually recognized the right to health, as also laid down in the International Convention, which was a case in South Africa, where the Treatment Action Campaign actually litigated against the Minister of Health for the access to the vaccines, not vaccines, but access to the medicines that women needed to prevent the, how do you call it, the HIV transmission from mother to infant. So in that case, actually, their claim was successful, and the court ruled that the state had to take measures to actually make up a program to have this medicine available for the mothers, and not only at private and special treatment centers. So there are some exceptions, but it is quite difficult to enforce this positive formulated human right. So what then should we say? Okay, so within a state it's difficult to have this claim. So is there maybe some obligation towards the other countries which have high incomes? Should they take up their duty to respect the rights to health in the international environment? And yes, so the available resources not only relate within a country, but also relate to the other higher income countries. And which is stated in a general comment is that that is even more so in humanitarian assistance in times of emergency. So the economically developed state parties have a special responsibility and interest to assist the poorer developing states in this regard. So there's actually more of a special responsibility to do this. So we have another, another Mentimeter question on this. So this is going to be about the role of the higher income countries in assisting the lower income countries to fulfill the obligations under the convention. So imagine, for example, Oxfam or another NGO like Amnesty sues Germany for not fulfilling its duty to ensure access to COVID-19 vaccines. So how successful would you consider such a claim? I hear you could not just choose one. So we have some text bubbles here. Not successful. Likely unsuccessful. Okay, someone wants to explain this, maybe? Yes. Mm-hmm. Yeah. Yeah. Yeah, so more, actually maybe not only the access, but also the organization of an international assistance and have a good working operation to give the said countries these vaccines. So in actually not fulfilling the duty to assist and to cooperate on an international level via international agreements and That's a good question. Well, I think we turn to that in the next slide, but maybe someone else wants to explain a little bit more on how unlikely this is.
Well, I'm just thinking about the precedent it will create, because then it seems like responsibility is so diffused, and everyone to every different, this would then be the start of something that I think
Mhm. Yeah, yeah, yeah. So, well, let's turn to the slides and see. Oh, yeah. Well, we have here a little headline from the website of Oxfam, actually. So, human rights advocates eye legal action against Canadian, German, Norwegian, and UK governments for global COVID vaccine inequality. So we don't know how far this actually is, this legal action, but we do know that it was more specified and more pointed at these countries that did not support the waiver for the TRIPS agreement. So that I have to explain maybe a little bit more on that, but I'm not sure how, how much time there is left, actually. No. So well, the TRIPS is probably familiar. It protects the IP rights on the patents of, amidst others, the vaccines. And India and South Africa proposed a waiver temporarily during COVID crisis to not well make these agreements with the private companies over these patents. So they were afforded the technical information and the patents and the well, also the other rights that were involved of creating the vaccines themselves. But actually, the developed countries are still blocking this this proposal by these two countries. So what the humanitarian right advocates state actually is that by blocking that, they might fail to in their obligation to respect the right to health and to assist on an international level to give the vaccines or to have the vaccines also to others. So that is what it was more specified. So by blocking it, they might, well, they might have some legal claim. I think I'm going to skip this a little bit further. So I think I just wanted to show that the international law regime, actually, we call it maybe it's sort of double-edged sword. So it both gives the, well, there is laid down the right to health at multiple places, but, well, there is limitations in the enforceability of it, and it's difficult to enforce it at domestic level, but also on the international level. So, yeah, maybe we should come up with another idea, and then we come here with the Pandemic Preparedness Treaty, because within the constitution of the WHO, there is the possibility to have a convention of, and to, well, we should be with 2/3 of countries in favor of it, but that's what we're in, what is in progress now. So March 2020, so that is quite recent, they started to draft a pandemic preparedness treaty, and well, maybe that will be a solution of more of a global law and equal distribution of vaccines. So, but then, yeah, who's going to execute it? Yeah.
Yes, thank you, Eline. So we've talked about inequities in vaccines, how that relates to the right to health. And then we end with this last part on, okay, what's sort of the potential step forward? And this pandemic treaty basically suggests that countries worldwide should be working together in case of a pandemic, as opposed to national governments basically doing their own thing. Now, if such a pandemic treaty were to be put in place, if a wide range of countries would agree to do so, then it seems likely that the World Health Organization would be the party to take the lead. Now, let's think a little bit about that. So if we move back to the Mentimeter, I'd like to help you to start thinking. So imagine there would be one party taking the lead in a pandemic response, one party making decisions about where to spend the money. And also, if we spend it on one specific pandemic intervention, then we can't spend it on something completely different. So what we've been seeing, especially in sub-Saharan African countries, is that other types of care, especially antenatal care, where women have to travel at frequent intervals to a healthcare provider, are being sort of cancelled as a result of COVID. And you can even ask yourself whether maybe the restrictions that relate to COVID have a larger negative effect, especially in those populations, compared to the benefits from sort of protecting people against COVID. So if we were to focus on such a pandemic response worldwide, would that sort of cover everyone's benefits? And would that help to identify what is relevant to populations around the world? Now, first, if the WHO were to be in the lead, they need some money for that, right? So do you have any idea the current operational budget of the WHO? Is it similar to that of the World Bank, the Erasmus Medical Center, or the Dutch healthcare budget in one of the recent years, like 2020? Yes, exactly. So the operational budget of the WHO is similar to the yearly budget of the Erasmus Medical Center. The first time that I heard that, I was surprised, because this is an organization that is supposed to take the lead in health challenges worldwide, and then its budget is only similar to that of one academic hospital in a city in the Netherlands. So this shows that if the WHO were to take the lead in such a response, it would be important for them to have additional funding. Now, of course, it would be very efficient if they could do it for their current funding. But the pandemic treaty also contains a part where the suggestion is that specific national governments would have to pay to the WHO for the WHO to take the lead in the pandemic response. Okay, if we move to the next slide, the next question in Mentimeter, I mean. So, is responding on such a worldwide level likely to be cost effective? Now, I can already tell you that I don't know the real answer. There hasn't been a study that really answers this question, but still, you can share your thoughts on this. So, should such a pandemic treaty with a worldwide response be implemented, looking at from sort of a cost effectiveness perspective? Yeah, you may also expand a bit on your answer if you like. So those who say that it's likely to be cost effective, could someone add why you think it would be cost effective to have one centralized response to a pandemic? Anyone who said yes want to respond? Right. So you.
I would have the purpose of, trying to prevent, a recession.
Yeah.
That should be the focus.
Yeah.
And vaccination rates help, and I think that's also what we have seen sometimes. They simply want to have vaccinations, that people will trade again and stuff like that.
Yeah. Yeah, so you're saying from an economic perspective might be effective, from a health perspective, harder to say, maybe not. Anyone who has like a different view on this?
I would say external effects require coordinated action, so therefore it's probably a cost-effective measure to do it worldwide.
Right. So like vaccines in general, there are large. Yeah. Yeah, any response to infectious diseases are beneficial not only to those who are receiving the specific treatment or vaccine, but are also effective for a wide range of other people who then don't get contaminated, for example. Yes, of course, good point as well. Okay, let's move to the last question, I believe, here in Mentimeter. So should it be one organization like the WHO taking the lead in a future pandemic response, or should the pandemic treaty be based on sort of a multi-country lead? So should it maybe be the European Union and the African Union and a range of other continents working together, or should it be the WHO? Now let me share with you that there was a quite critical report on WHO's response to the Ebola crisis. And there, the report basically said they were relatively slow. They were late to identify the challenges around Ebola. And even when they had identified it, it was hard for the WHO to take the lead and to really ensure effective measures on the ground. So there is that worry when it comes to WHO taking the lead that might also relate to this relatively small budget that they have. Okay, so it seems that the majority suggests to make it more of a multiple group effort. Well, in the interest of time, I'd like to leave it here. Thank you very much for your input, for sharing your thoughts, and we look forward to taking this further whenever relevant to you. Thank you. Yeah, I think there was a slide on like the lunch break, right?